So thanks for putting up my slides. So I'm reporting as the principal investigator for a project called Import. A large cast of characters mentioned here. Some of them were actually in the overflow room. Lots of disclosures. I consult for many major biotechs, pharmas, and contract research organizations. Nothing to do about that. And so I'm representing Import. So Import is the archival repository for NIAID, National Institute for Allergy and Infectious Disease. These funded consortia. It started about 7 years ago, competitively renewed last year, and I've taken over as the principal investigator. In the beginning, the intent was to share immunology-related data like flow cytometry, influenza measurements, and then we realized actually we were releasing clinical trials data, raw, individual-level, de-identified clinical trials data. And so we have nearly 100 studies and trials released. And just to go right to the model, this is the model. So we take data from funded consortia, for example, Immune Tolerance Network and kidney transplantation, many other studies. And they have their own data sharing policies. So we don't write them. We can kind of share what others do in their peer group, but they have to write their policies. But when they've written them, we help them enforce them. If they say they're going to share the data, we're ready to take it. So we have hundreds of end user downloads of this raw clinical trials data. We often get the data from the consortium researchers or preferably from the contract research organizations. Many of these large studies obviously go through CROs, even academic ones, and the data is organized there and it's deliverable in a kind of standard type of way. And we have genetic data and gene expression data. Genetic data goes through NIH's established mechanisms, so we don't reinvent any of that. We currently give out literally trials data in tab-delimited text files in MySQL format, but also moving towards CDISC Bridge. It's a standard that's used by the pharmaceutical industry, and we thought that we could use that for data release as well. So it'll be very quick. 10 experiences, 10 reasons why we've learned true open release is the way to go here. I'm not going to talk about all of these in detail, but I'm just going to highlight some of the pluses and a lot of the risks, as Ida told me going into this. First of all, obviously, reproducibility is a no-brainer. John Ioannidis is speaking tomorrow. I don't need to go into that. I just want to show you on the top left here a real-world example of reproducibility. On the left is a figure from an actual paper. And on the right is when we re-downloaded the raw data from our own site and tried to reproduce their data. And we get the same kind of graphic. We've added color. We get the same p-value. But then immediately we start to ask, well, why did they look at only 18 months when they gave us 3 years of data? And when you look at a longer time frame, you actually might lose the p-value. So it's not originally incorrect or deceptive. And what we're finding is something new, but where do you put a piece of data like that? Maybe PubMed Commons or something like that, but this is not really challenging the paper, but it's actually maybe highlighting something that was not really looked at in the original paper. That's a risk. Transparency, I don't need to talk about Keith Baggerly, IOM reports there. Returning data to community, I mean, for example, not individual gets their own data back, the community gets data back on their own disease, for example, support organizations. The risks that we've already seen are maybe consortia, maybe patient support groups, maybe news reporters don't really fully understand the statistics involved. Maybe we don't do a great job of explaining every last test we're doing in the trial publication so that they can easily reproduce that. And obviously you can get contradictory results. Of course, supporting public policy, Tamiflu, Roche, BMJ, I don't need to tell this audience about that. Very briefly, visibility into failed trials. Of course, you all know that. Speeding results reporting, obviously. We've seen even the data that we've released, it's taken 4 to 6 years for the papers to come out from these trials. And now we're releasing the data, and one would think that this might speed that up. Enabling learning and new ventures companies based on the raw data come up with diagnostics I'm not going to spend time on. I'm just going to spend the rest of my time on just 2 case examples, real-world examples of what we've done. On the left is something we call a digital comparative effectiveness. So we've already released 4 trials on children getting new kidneys, kidney transplantation. And these are 1 or 2 arm studies. They lasted a decade. Many of them have been published in many different venues. But we realized if the entry criteria were all the same and the outcome measures were all the same, and actually the trials are otherwise comparable and some of the drugs are the same, you can see the different colors matching, why not run the whole decade as one big meta trial? Okay, just one big meta trial. And you can do that, and you can do digital comparative effectiveness, looking at which drug out of the whole set actually does better for these children. And you do get some answers back. But the issue is then immediately you start to get challenges, especially from the original authors, about how you're going to cite this. Shouldn't the original authors be authors on these new papers? And even more importantly, they start to say, well, you didn't know X, Y, Z about that trial, kind of insider knowledge. But if it was truly insider knowledge, why wasn't that described in the paper? Right? Then others should have known about it too. So this process kind of uncovers a lot of skeletons sometimes in closets here. So, but it's possible to do comparative effectiveness this way. On the right is another kind of promise, is this idea of a precision subsets. It's a drug There's an old way to treat vasculitis, 50-50 chance it works. A new way, expensive way, 60-40 chance, non-inferior. Can't really say it's better. You can dive into data. You can find a brand new blood test that they measured that actually tells you as a doc which one you should use for your own patients. But now the risk is, do I include them as authors? That's great. But now I can actually file intellectual property on this marker as a companion diagnostic. It's neat that me as a neutral third party, I can do this kind of patient subsetting, but then I can kind of own that, or my university, and move it forward. And so that's a risk there. So I'm just going to stop there.
Great. Thank you. Thank you.